Welcome to Emergency Chaos, where we provide tips and tricks to make you a better ER nurse. Today, I'm going over my approach when you are starting off the day with critical patients, or in other words, when you come onto the unit and are assigned the critical patients. Thank you for your time. Like with any patient in the ER, the initial impression is very important. The initial impression is simply taking a look at your patient and noting if they are in any active distress, taking a mental note of key things you see to gauge how sick they are. If I know I'm getting the critical patients before even getting a report, I'll walk by the rooms and take a quick glance, noting if they are intubated, if the sedation is working appropriately, taking a quick look at the vitals, at how many meds are hanging, and looking at the patient. Is the patient in any active distress? Like, are they having noticeable airway or breathing problems? Are they guarding? Are they super pale? Or are they completely sedated if they're intubated? Taking a quick look at those things to gauge how sick they are. And I'll also at times take a quick look at the room, noting anything that may give me clues as to what happened to the patient. If the crash cart is out, I know that the patient was very sick. If I see blood tubing, I know the patient got transfused. Essentially, taking just a quick look around the room to gather clues as to what happened to our patient. In the ER, you're going to have nurses who love bedside report and others who don't really mind. That kind of just go with the flow. For me, when it comes to my critical patients, I prefer having bedside report. I feel like it's much safer because I feel like I get a more complete report, meaning all the crucial points that need to be passed on to me do get passed on to me. And most importantly, also, I'm able to ask any questions about anything I see right there and then and get answers from the previous nurse. For example, let's say you have a neuro patient. You should do an assessment with the nurse giving you a report so that you have a good understanding of their baseline so that later on, if something changes, you're very much on top of it. Otherwise, if a change happens in your patient, you may not be able to catch it as quickly as you would have because you did have a baseline with the previous nurse, right? Again, I believe it's much safer to do a bedside report on any critical patient. And then after getting bedside report, I typically go one of two ways. If my patients are stable at the moment, I may choose to do a chart review. However, if something needs to be done, like let's say your patient's blood pressure is tanking, then I will address that thing first before I do anything else because that's the life-threatening thing that's in front of me, so I'm going to address that first. If I decide that my patients are stable, I'll quickly review the charts for the key parts. I'll verify the patient's chief complaints and their admitting diagnosis. I'll review the labs, imaging, medical history, allergies to medications. I'll review the patient's medication administration record, and I'll ensure to review what the plan is for the patient and what is pending so that I can start planning and how I can get things done. So very important. Everything on the chart review is important, but for me, I like knowing exactly what the plan is for my patient and what's pending so that I can start planning my day in my mind so that I can get things going. For example, let's say the patient has a CT pending or repeat labs or a med to be administered. I'll start planning when I'll be doing these pending tasks after I have assessed both of my patients. But again, if one of these things is crucial for the patient's plan, I will do that first. Now, if something pressing needs to be addressed, then I will be doing that first. Things that are super pressing that if you come on, you take report can be like your patient's blood pressure tanking. They start having new heart rate or rhythm issues that are compromising their hemodynamic status. Your patient is desatting out of nowhere. Your patient is needing more sedation, meaning if they're intubated and they're just waking up, they're reaching for their tube, they need to get more sedation on board. So I'm handling that first, right? Because if I don't and the patient extubates themselves, that's going to be a whole other world of trouble, right? Or other issues can be like if your patient's even seizing, I will be addressing those things first before I do anything else. Or even if your patient needs to go to CT at that moment because the results of that CT could change the management of that patient, then I will do that first because that's in the patient's best interest, right? And everything else, as long as it's not life-saving, I can catch up on. You do the life-saving things first and then you do everything else, right? And then, so you did your initial impression. You got bedside report. You address any issues that needed to be addressed and are now going to go into the room. So now what? Well, If my patient is stable, I'll start with taking a look at the vitals and familiarizing myself with the ECG rhythm. I'll review all of the medications they have infusing, ensuring the pump was programmed correctly and ensuring it is the right med, and at some point looking over the MAR and making sure there are orders for the meds. I'll look at the ET tube, looking at the size and the length, as well as the vent settings and if the patient is synchronous with the vent. Then I'll look again at the sedation so I know which med and at what rates they're going at. I'll assess the patient's access sites, whether it's IVs, central lines, arterial lines, chest tube, etc. Anything that's poking my patient, I want to take a look at it. I'll take a look at the OG tube, ensuring it is secure and noting the length. I'll look at the urinary catheter, ensuring it is in a good position, not kinked, as well as the patient's urine, looking for cloudiness or changes in color. And now I'll ensure that the patient has soft restraints if intubated, as well as ensuring there is an order for them in assessing the extremities to ensure that the soft restraints are not too tight or causing damage. You're going to get to the point when you do everything on the previous slide plus your physical assessment simultaneously. You're going to just go from the top to bottom and assess everything. You just need to ensure that you spend a little extra time assessing the reason why your patient is there. For example, if your patient is a CHF exacerbation patient, listen to the lungs, listen to the heart, note their work of breathing, look at their SpO2, their blood pressure, familiarize yourself with their ECG rhythm. Note if they have any edema, check their cap refill, check their pulses. So whatever your patient was there for, you need to make sure that you spend a good amount of time. Sometimes patients will be complex, so you're going to have to do a thorough head to toe. But if they're there for just one specific thing, make sure you hit that and you understand it and you have your patient's good baseline in your mind so that if things start to change throughout the day, especially for your critical patients, especially if they're intubated, because they won't be able to communicate with you. So for these patients who are intubated, it's super important that you get a good baseline because they're not going to communicate back with you. So your initial assessment is very, very important so that you have something to compare to back to throughout the day. Like always, maintain patient privacy, but you need to ensure that you're assessing everything in your intubated patients. For example, if they have a FEM central line, you need to go and look at that access site to make sure there's no overt like bleeding or a big hematoma just developing, all right? Or if the patient is there for a GI bleed or any gastrointestinal issue, you need to visualize the abdomen. So you need to lift their gown up. Of course, always keep patient privacy. There hasn't been a lot, but there's been new ER nurses who will kind of assess their patient without lifting the linen, without lifting the gown. No, you want to go in there because your patient is not communicating back with you. So you want to ensure that you see everything that you need to see. Thank you for your time today. I hope that I was at least able to teach you one thing. If you want to keep learning, I've listed my favorite ER nursing related books in the description, with my favorite being Sheehy's and the Case Files. As well, please take the time to watch my other videos. Also, if you would like to help support the channel, I have nursing stickers and shirts on Redbubble that you can check out again. Thank you for your time today. And as always, teamwork makes the dream work. And here at Emergency Chaos, we are proactive, not reactive.